morning. It's such a treat to get to follow Mal because his talks are always so amusing. Well, I have the great privilege of talking to you. I think I have two talks back to back here. The first one's on traumatic aortic injury. So is there a clock? Oh, there is. Good. 5:34? Does this get reset? There we go. All right, so I'm going to assume you guys know a lot of stuff already. I'll just sort of go through this, and we'll try to stick to the interesting points. So, as you know, traumatic aortic injury is a big problem. I come from UCLA, California. The most common cause is crashing $200,000 Ferraris, like in this photo. They go very fast, and as you know, when this happens, it causes a rapid deceleration when you hit something. We'll talk about that in a second. So there are a lot of deaths from motor vehicles. This is old data, 2010. And if you look at that almost 38,000 number, you find that a big chunk of those, about a third of them, are related to blunt thoracic aortic injury. And if you compare that to just deaths from aneurysms and dissections, you realize what a big problem that is. So as I was saying, this is really a deceleration injury. The arch is being fixed and the vessels above being mobile lead to several points, obviously adjacent and sort of across from the left subclavian artery being the most common point where these injuries occur. It's kind of funny when you think about time going by, things seem so, when people are ahead of you or things are ahead of you, they seem so much older than you. And when you look back, things seem so recent. So for Mal and myself, when we were residents, I assume it was the same for him, they had just started the study when I was like a trauma 1 and 2, where when a patient came in and they had a widened mediastinum, they could sign up for a study where they'd get this thing called a CTangiogram instead of going right. I know you laugh, but this is true, and it seems like yesterday. And then if the CTangiogram showed something, then they'd get something called a thoracotomy, which was apparently they'd open up the chest and spread it with this thing with some Italian name, of Funicello or something like that. And they'd fix the thing. So it just shows you how radically things have changed. And this was when I was basically not that far in training from where you guys are now. But anyway, as you know, now this has really changed. You see something suspicious, you always have a mechanism when the patients come in as a code trauma. Chest x-ray looks a little funny. Most of these patients are just getting CTs anyway, and they get their CTangiogram. And then the latest change is really using more IVIS to try to figure out what's going on. So CT scans are very good at showing that there's a problem. You guys can all look at this. I don't think I have a pointer here, but you guys can all appreciate the aortic pathology there. And then, like I said, nowadays, if you're going for an aortogram, it's usually because you're getting the problem fixed. But you could certainly see very clearly an injury like this. There's not a lot of controversy about whether there's an injury or not, but there are a lot of advantages to IVIS. So IVIS doesn't use any contrast, no radiation, obviously. It's real time, so you can look back and forth. You can get measurements and get some sense of morphology. One of the problems with CT scanning is there are some false positives that can occur. Now, Dr. Azizadeh and his group did this study basically comparing IVIS to CTA in this indication and found that IVIS was both more sensitive and more specific and prevented some of the false positives that we see with CT scanning. So how many of you guys have seen aortic spindles? Y'all know what aortic spindles are. So this is just a congenital thing. But you imagine someone comes in having crashed their car with a wide mediastinum, and you see this on a CTA or an angiogram, and it's very, very concerning looking. But this is just a benign congenital issue. How about ductus diverticulum? Any of you guys seen those before? Damn, so I've taught you 2 things, maybe. If half of you remember one of those, that's something. So ductus diverticulum is also a benign problem, but obviously if you see something like that on an angio or a CTA following blunt thoracic injury, it'd be very concerning. And then you can have bronchiointercostal arteries, if they're large, also appear like pathology. When I'd spoken before about how things were back in my day, but once thoracic endografts came online, it didn't take long to start applying these to this very precarious situation. And it was shown pretty quickly that they worked very well in this setting. So I just want to go over in my last 5 or 6 minutes here basically just some concrete points and fundamentals of dealing with blunt thoracic trauma. So with modern imaging, we've really realized that thoracic aortic injuries in the blunt setting really represents a spectrum of injuries. And it really has to do with the portion of the aortic wall that's involved. And so that's really the thing at the end of the day that you want to know is, what type of injury is it and how does it have to be treated, or does it have to be treated? So again, IVUS plays a huge role. Really what you're seeing with IVUS that's so helpful is the layers of the aortic wall, right? And you guys all know the layers of the wall. You've seen these pictures a million times, the intima, the media, the adventitia. And that's really the fundamental concept when looking at blunt thoracic injury. So you'll see this picture a lot. How many of you have seen this diagram before? They're using Dr. Azizadeh's article. And this is really what it comes down to, right? So for grade 1 injuries is basically just an intimal injury. It shows up great on IVUS. It shows up great on reconstructed CT scans. It shows up great on your axial images. Grade 2 injury is an intramural hematoma. Again, the nice thing about IVUS is it looks exactly like you'd think it should look on IVUS, and you can see the hematoma there on the wall. Again, shows up great on your CT reconstructions and on your axial imaging. Grade 3 is a pseudoaneurysm. Again, we've sort of left the realm of subtlety here. If you can't see this on any of these imaging, you probably shouldn't be looking at these images. And then grade 4, yeah, kind of like Mal was saying about his questionable, funny-looking rupture on his last talk. Same thing here. It looks bad. So how do we treat these? So grade 1, basically these can be followed, and we'll look at an example of that in a second. Grade 2 and 3, the data really are not as robust as they are for more severe injuries. Grade 2, we treat, some of these will heal, but I think where we stand now, these need to be treated, certainly for grade 3. And then grade 4, you know, like you would expect at the extremes of grade 1, you can get away with doing nothing, and then grade 4, these are urgent, life-threatening problems that need to be dealt with right away. There are clinical practice guidelines from the SVS. That's not the most rigorous data, but they have led to the suggestion, if you look at this document, that endovascular repair, should be performed preferentially over open surgical repair, and that this is better than non-operative or expectant management for all but the type 1 injuries. So here's just an example of someone with this type 1 injury, just this intimal tear. You can see on the left side of the screen at the time of the injury, and then a couple months later, keeping an eye on it, and it basically heals, which really isn't surprising. I'm sure you guys have followed small dissections and the like, and the aorta does have a pretty good chance of repairing itself in these situations. And then here you see a very dramatic grade 4 blunt thoracic injury with these fancy 3D reconstructions. And then something like this obviously can be treated. Here the subclavian was embolized and it was covered up. So there have been some milestones in the treatment of blunt thoracic aortic injuries, distal aortic perfusion many years ago, delayed repair, and then TEVAR. So the question is kind of, well, has TEVAR made a difference in outcomes since this has become available? We'll just sort of run through these data. So you have a bunch of blunt thoracic injuries. As you would expect, most of them occurred from motor vehicle accidents, motorcycles, some pedestrians, falls, and a couple of sporting injuries. With 185 repairs, and this is over time, so there was an open clamp, bypass, open with distal aortic perfusion, and TEVAR. And there's definitely a trend towards better outcomes with TEVAR as would be expected. You can see that better here, just looking at operative mortality, sort of in the older era, distal aortic perfusion, delayed repair, TEVAR introduction, and you can see sort of the drop in mortality over time. So this clearly a mortality reduction with the introduction of TEVAR for these injuries. Can be seen with actuarial survival as well. So what lessons have we learned? So the big thing is that the classification has big prognostic significance. You can treat these grade 1 injuries medically, and that TEVAR over open repair is really the appropriate repair for patients that have anatomy that's conducive to this. So I'll just finish with this, the Aortic Trauma Foundation Center study. This is multiple centers involved in this. Multiple injuries in patients. So just looking at the types, a quarter of them grade 1, about 20% grade 2, 50% grade 3, and the remaining grade 4. TEVAR versus open basically found a lower overall mortality with the TEVAR cases, and then a lower aortic-related mortality as well. And if you look at the specific predictors for that, just looking at the bottom at the aortic-related mortality, the injury severity score, the type of injury, and then using TEVAR all led to decreased mortality. So that is our coverage of that, and I think we're right on time.